much more interactive. I think the recording has started. So just to somebody who would be watching the recording, just to give them a brief that we would be talking about fluids. And since it's a topic which is so much important, since most of the patients which we receive, whether in emergency or intensive care unit, are on IV fluids or given IV fluids during their resuscitation or during their stay into emergency or ICU. So that's why I think the more we talk about fluids, we will be able to learn and understand the nuances related to the fluid administration. Starting with the talk, I have to declare my conflict of interest, and that is very similar to this gentleman. I won't be lying because this is something topic which is very close to my heart, and also just because I'm also co-author of this blue book. If you can mute your mics, it would be easier for everyone else to understand what we are speaking. Okay. The book has already been downloaded by more than 1.5 million healthcare professionals. So I believe the book is quite popular. If you have not downloaded it yet, this is a QR code you can use to download. It's a free access book from Springer, very updated on whatever we do in terms of fluid management. So please feel free to download this book. I would be sharing the link in the end also, those people who are joining late. Why this is important, we will be seeing in very, very brief, how fluids are important. Let's start with a case. Case most of you would have been seeing into your, emergency, or if you're working in ICU, in the ICU. A 62-year-old female with pain abdomen and history of nausea, vomiting for one day. Patient had previous history of diabetes, other comorbidities like ischemic heart disease, history of a peptic ulcer, hypertension. She was febrile on presentation and hypotensive. There were signs of mottling as well. Blood gas, the first investigation which we usually do at point of care, showed metabolic acidosis with lactate of 5.2, and her sugars BM in UK we use that as millimole, so it's 5.2, which was, I can say, normal, or it's above 110. The patient had perforative peritonitis as the possible reason of her pain abdomen. So it looks like a surgical abdomen, and patient is febrile and hypotensive. If I ask you, do you think this patient is hypovolemic? Most of the people would say yes. But when we say patient is hypovolemic, what is the way you assess a volume status of a patient? I think this is again one big challenge which we have to face. So if these are the option, what would we think is the ideal one or the best one to say that this is the parameter you would use for a volume assess status of the patient? You can post your answers in the chat box.
Estimate volume status. This is the most important clinical parameter. Estimated volume.
அவர் ஏதாவது சொல்லுவார் கண்டிப்பா.
Yeah, please use the chat box to answer. Sir, you are on mute, sir.
Okay, sorry. Okay, just 10-second more. If you want to post your responses, please feel free to put up into the chat box.
Patient kahan hai?
So this is the question. We have a patient who is hypotensive. Suspected source is surgical abdomen, which could be a perforated peptic ulcer because there is a background of peptic ulcer. So this was the patient. And the first question is how you assess the volume status of the patient. You can post up your responses in the chat box. Okay. Just for the sake of the time, we will move ahead. Now, the second most important thing is most of you have seen this patient who is hypervolemic and you wanted to assess the volume status. That was question number one. And definitely, since the patient is hypotensive, I won't argue on that, that most of you would like to give some sort of fluid bolus to this patient.
Only half an hour, okay? Reduce.
So which fluid bolus will you use to resuscitate these patients? First is 5% glucose saline. It's a saline or 0.9% saline, Hartmann solution, plasma light, 5% albumin, volulite, gelofuscin. I've tried to incorporate most of the options which we have. There may be some options which may not be available to you or applicable to you. So feel free to choose whichever you are doing, on a daily basis. The two most common things which you need to do, a volume status and then a fluid bolus. I think in this patient, the first two priorities always to look at whether the patient is hypovolemic, euvolemic, or hypervolemic. And if I say it's hypervolemic, what is the way to assess? So that was question number one. And the second question was, what will be the fluid of choice for resuscitation of this patient? So I see many of you have put saline, some of you have put plasma light. I could see also an Hartmann, few Hartmann, RL, okay, 0.9% saline, 5D with 0.9% saline. Okay, yeah. So that reflects in a way, in a nutshell, what all we do on day-to-day practices, and there is quite a bit variability the way we do. And this was something not unique to this group. We actually did this survey, which was published in this journal, which was Journal of Critical Care, a good impactful journal into intensive care. So we did this survey as part of International Fluid Academy few years earlier, and it was a global group which participated into the survey. It included intensive care physician, people who are working in emergency, so both emergency and intensive care physicians were there. Approximately 97 countries participated in this global survey. And to tell you, if I say the passing percentage is 50%, the average score in this group was only 46%. It means the group was actually failing into this survey. And that, to tell you, the questions were very similar to which I put just now. The questions were related to the volume status, about the IV fluids, and the same question which I asked you right now was put up into this survey also, how to assess the volume status of the patient. Unfortunately, we do not have a right answer for this. There is none of the above. There is no way you can use either of these parameters to assess the volume status of the patient. Most importantly, this is a multiple things which you need to consider. Most of the tests which you usually believe are assessing the volume status are actually looking at responsiveness of the fluid, or a preload responsiveness, which we will be seeing in few slides later, like a passive leg raising test, or giving fluid challenge and then looking at blood pressure or mean arterial pressure or cardiac output. These are the things which we look for, checking the fluid responsiveness rather than the volume status of the patient. So none of the above is the right answer for this. And to tell you, in that survey also, it was only 8% of the participants who gave the right answer. And this is something so important, but at the same time, very, very much commonly, misconceived by the people, that we are actually looking at the volume status by looking at the breathing rate, pulse rate, urine output. No, these are not the parameters to assess the volume status of a patient. Then the second question which I asked you was, what will be your preferred IV fluid? Most of you have actually chosen in one of these things, 0.9% saline, plasma light, and Hartmann. So these are the choices which also have been given by this group. And the right answer is balanced solution. We will be talking a bit more as we go further on this. 0.9% saline and Hartmann. What are the problems? Is an Hartmann good? Yes, to an extent good, but we will be seeing the evidence, what evidence says, and why saline is a problem for these patients, for resuscitation of these patients. So what do you mean by resuscitation? Resuscitation is a very important step which we do for any patient who presented with us in shock. So it's basically a way of managing the patient with profound alteration in perfusion. And this could be seen in patient with sepsis, with patient with trauma who are presenting with hemorrhage, or patient who are in profound dehydration due to any other reason. So it's a resuscitation which is to be done to ensure that their organ perfusion is okay. Please, if you can put up your mic on the mute, it would be nice for the rest of the group. The other thing was, why we need to do this, because we understand that time is life for these patients. We also understand that time is life for many other patients who are presenting into emergency, like patient with stroke, where 90-minute door to needle time is important to reperfuse the heart. Patient with acute coronary, patient with stroke, 4.5 hours is that window period. Similarly, we have window period for getting a imaging like done for these patients. There are other windows for 1 hour, like for an antibiotic. Similarly, we also believe that giving IV fluid is the most important step whenever there is a patient in hypotension, and delay in the resuscitation of these patients will leads to higher mortality, and that leads to believe that there is a golden hour almost for everything, and we tend to resuscitate these patients most likely with a fluid bolus, and that's what we do most of the time. So whenever we actually give fluid bolus for resuscitation, this is, and what are the indication we give fluid bolus? Whenever we see a patient with hypotension, that I think all of you would be doing most commonly. Whenever you see a patient with hypotension, you tend to give a fluid bolus. Whenever you see a patient who is continuous to have a tachycardia, okay, let's give another fluid bolus. Patient is oliguric, I don't know the cause, possibly it's a pre-renal, so let's try a fluid bolus. Patient has high lactate, give another fluid bolus, acidosis, base excess, and so on and so forth. So most commonly our response to many of our common physiological abnormalities is to give a fluid bolus, and without even judging whether we are doing or right or wrong. More commonly, we give a fluid bolus of up to liters and sometimes even 3 to 4 liters, depending upon how the patient has responded to that fluid bolus. And what we see, and this is not something very common, a patient by this third or fourth day when they are in the intensive care unit, especially patient like this who had a post-operative course, definitely she had an perforative peritonitis. She was resuscitated, and after that had a surgery. Post-operatively, by third day, the patient creatinine is jumping by 142 to 186, and the patient looks almost 3 times of what she was seen in the emergency. And we believe this is all part of the disease process, but this is not everything due to disease process, but also something which is happening because of the management which was done initially, and the continuous resuscitation which was done with fluids preoperatively, intraoperatively, and to an extent postoperatively. So that is something which has been understood in last few years to decades, something known as fluid accumulation syndrome. So we understand now that hypovolemia is bad because it contributes to hyperperfusion. So if patient has hypovolemia, they have high risk of dying because of multi-organ failure. But there is also a component, the patient who can tend to get over jealous fluid prescription or who lands up into the hypervolemia, they also have a worse outcome. And this worse outcome is because of the organ failure, which are very similar to the patient with hypovolemia. So they also will develop acute kidney injury. They will also very similarly develop a respiratory failure, which will be different from the primary disease process, but due to the iatrogenic resuscitation of these patients. They will develop something known as intra-abdominal hypertension or even abdominal compartment syndrome. And sometimes because of all this may develop even an osmotic leak. So hypovolemia is bad, but do not forget that hypervolemia is bad, and the balance somewhere lies between tend to correction of hypovolemia, but to make sure the patient doesn't go into hypervolemia. The evidence on that hypervolemia or so-called fluid overload, there is now enough evidence, and this particular study which was actually done in patient with sepsis and septic shock, where we believe fluid resuscitation is an important part. So by third day, if these patients had a fluid balance which is in cumulatively positive, so in 72 hours of resuscitation of these patients, if their cumulative fluid balance is positive, they had a higher risk of dying as compared to somebody who did not have a cumulative fluid balance positive. And what was more important was there was a dose dependent relationship. So higher the amount of fluid balance positive, higher the risk of dying. So there are two important things which this meta-analysis picked up. Even in the patient where we believe fluid is initial resuscitation of choice, the patient, if they continue to get extraordinary fluids in the first 3 days, they have a higher risk of dying. And the death was also independently decided by their amount of cumulative fluid balance. So it's very important that every fluid you are giving, every ounce of fluid you are giving, need to be balanced out to the resuscitation goal, but also to be balanced out whether they really need that fluid, or most importantly, whether they are tolerating that fluid or not. So the concept of fluid resuscitation has now been extended to fluid tolerance, which we would be seeing in subsequent slides. And why we actually give fluid for these patients? Because we believe by increasing so-called preload, you are increasing the cardiac output of these patients. And what is preload? Preload is something which is there in the venous circulation, the return of the venous circulation on the right side of the heart. So by improving the right side preload, you are in fact improving the right side cardiac output, which will increase the left side preload and eventually increase the cardiac output on the left side, which will improve the systemic perfusion. So that's the basic mechanism of a Frank-Starling mechanism, but we understand that the curve on the Frank-Starling differs depending upon the heart rate or depending upon the heart status of that patient, but also whether the patient is lying in the flat portion, which is the upper portion of this curve, or whether the patient is lying on the steep portion of the curve. So if the patient is lying on a steep portion of the curve, you may still get an improvement in the cardiac output. But if the patient is lying in a flatter portion of the curve, or if the patient is already having a pre-existing, some sort of cardiomyopathy or some sort of cardiac dysfunction, this steep portion of the curve is very, very small. More likely, by giving them fluid boluses without assessing their response, you will be landing into a situation of fluid unresponsiveness, or your cardiac output won't increase. But this is only to check whether they are fluid responsive or not. Whether they are fluid tolerant, whether they are not fluid tolerant is a separate thing. So this is an important step or important thing which we will be understanding in the few slides later. That yes, the first step is to see whether the patient needs fluid. If they need fluid, whether they are fluid responsive, which means when you are giving them fluid, whether they are getting their cardiac output increased by giving that fluid or not, because that's what you ultimately want to do. If you want to improve their cardiac output, that's the only way to improve their perfusion. So that's the main reason you give fluid for these patients. So that's why you should check for a fluid responsiveness in these patients. And why this is important, because we saw a couple of slides back that fluid accumulation is bad, and it has been linked to higher mortality for our patients. Cumulative fluid balance in 3 days linked to higher mortality and definitely higher risk of dying into the ICU within the hospital. And unfortunately, most of the surgeons and clinicians do not care much how they are treating the patient, especially they do not understand what is a fluid accumulation syndrome. It is not always because of a disease, but also because how we treat these patients. So it's a mix of both. We cannot say if patient is bloated up by third day, it's all because of the disease itself. It also because we have not managed them the way they should be managed. So fluid accumulation syndrome is real, and that's why fluid are drugs the way they should be treated, the way we should be using them, the way we are using any other drug is the principle, because harm do happen with using of a fluid. And that's the principle which was thing which was mentioned by Professor Manuel Brain, which is very much extensively elaborated in the book which I showed you earlier. And of course, you would have again an opportunity at the end of this talk to download the book. So this is something which he talked about a lot, that the use of fluid into intensive care unit should be based on resuscitation, maintenance, stabilization, and then there is a phase where certain patient may actually require a de-resuscitation. We will be focusing today, just for the sake of the time, and most importantly because many of you are actually working in intensive care, not intensive care, you are working in emergency unit. So resuscitation is where you are much more tackling patients on a day-to-day basis. So we'll be talking more on resuscitation, but yes, how to deal these patients has been elaborated not just during resuscitation, but all throughout the phases of resuscitation, optimization, stabilization, and evacuation. The important message so far is IV fluids are not innocents. They are drugs. The way any drug you should be using, the same principle should apply to IV fluids. So what should I do? The first thing I should tell you is that though certain guidelines still do recommend 30 ml per kg, but we cannot justify anymore that every patient need 30 ml per kg. We should have these tools even in the emergency unit to understand whether the patient need fluid, and the reason you are giving fluid is actually to increase the cardiac output. And how to check that? By checking fluid responsiveness And these are the various tools which you can use by looking at IVC, by looking at pulse pressure variation and expiratory occlusion if the patient is already intubated. Similarly, if the patient is intubated, you can use a tidal volume challenge, which was the one test actually invented in India by Professor Sheila Maitra. I think there are various tests depending upon whether the patient is spontaneously breathing, whether the patient is not spontaneously breathing. Some of these tests have their own limitation. That could be a talk for another day. But yes, you should use after initial fluid bolus some sort of parameter to assess whether the patient need fluid in terms of fluid responsiveness or not. So these are the three questions which you need to answer. Whenever the patient need, you are actually giving a fluid or giving a more importantly a fluid bolus, whether the patient cardiac output is really low, that should be the first thing. So if patient mean arterial pressure or especially the perfusion status is fine, you are need not to consider a fluid bolus. So whenever you are giving a fluid bolus, the main idea you wanted to give a fluid bolus is to improve the preload or to improve the cardiac output. So if the cardiac output is low, that should be the first criteria or the first thing you should consider before starting any fluid. The second thing is whether the patient is preload responsive, and that's the time where you should consider these two tools, the one which I showed a slide earlier. So if patient has low cardiac output or a hypotension, then you should check for a preload responsiveness by one of the tools. And if patient is preload responsiveness, still you need to make sure that patient can tolerate that fluid. And this is a concept which has been recently understood as we understood the problems which can happen with fluid accumulation even in patients with initial who were fluid responsive. So fluid responsiveness doesn't tell you that patient actually can tolerate that fluid which you are giving. So maybe you are increasing the cardiac output, but at the cost of worsening the organ perfusion, especially in the lungs or in the kidneys, by creating some sort of known as venous congestion. So fluid tolerance is different from fluid responsiveness, and I think three things need to be answered before you actually give a fluid bolus. So when I have talked a bit more about fluids, can we consider vasopressors early in these patients? And actually there is now some evidence which talk about that. So early use of vasopressor like a norepinephrine in septic shock resuscitation. So, and this particular study actually showed that significantly higher shock was able to control when you used a vasopressor early. And why this is because in a septic shock, as we understand, there is no true hypovolemia in most of the patient with sepsis unless there is a sepsis which is happening because of a dehydration, because of some sort of vomiting or a diarrhea. Like in our patient, yes, to an extent they will have a hypovolemia, which is true, while most of the other patients who have developed septic shock, they do not have actual real hypovolemia. It's only the peripheral vasodilation or the stressed volume is really into a vasodilated pool, and that's the reason the venous return is low, and that's the reason their cardiac output is low. So by using up something known as peripheral vasoconstrictor like a norepinephrine, you actually stress that volume, and there is some evidence that starting the vasopressor early, you can reduce the amount of fluid which you need to resuscitate these patients, and the outcome or at least the shock reversal would be better in these patients, and that evidence is also been seen in other studies. So early initiation of norepinephrine is something which is catching up now. So one should not wait for finishing up your 30 ml per kg or maybe 60 ml per kg during resuscitation. If you are suspecting this patient is predominantly having a vasodilatory shock, then considering an early initiation of norepinephrine in these patients may actually have been found to reduce the short-term mortality and also have been found to reduce the amount of fluid we would be giving to resuscitate these patients. So we learned that every patient do not need 30 ml per kg. The second important message is probably certain patients can benefit from your early start of vasopressor. So as we understand now, we do use peripheral vasopressors. So do not wait even for a central line to start your norepinephrine. You can start peripheral vasopressors depending upon your institutional protocol. But importantly, think every time you give a fluid bolus by answering those three questions. So far we have talked about how to judiciously use the fluid and how to consider the vasopressor. Now comes the other important part is what should I prescribe? Again, the question which I asked in the initial part of the presentation, what would be your preference? So most commonly one of these things, either some sort of a crystalloid like a saline or a balanced solution, or some sort of a colloid like an albumin and a gelatin. We know that starches have already been removed from the market. So these are the common choices which you have on the bedside day to day. And just to make you understand a bit more, the people who do not know what is a balanced solution. So balanced solution is based on the content of that solution. So how we calculate balanced or unbalanced is by looking at something known as strong ion difference, which is a difference between strong cation and strong anion in that fluid. So every fluid which we use, and these are the common fluid which we use. So every fluid on the shelf will have a strong ion difference of 0. That's the way they are stable. If they do not have a strong ion difference of 0 when they are on the shelf, they cannot be stable. The only thing is what happens to them when they go inside the body or inside the plasma. That is more important to us, because some of these constituents of these IV product IV fluids, they get metabolized very rapidly as soon as you give them within the plasma, and their strong ion difference changes because one of the product has been metabolized or one of the cation or anion has been metabolized, and that changes their strong ion difference. So what we are talking about is something known as strong ion difference in vivo rather than in vitro, because in vitro every fluid will have a strong ion difference of 0, and that's the reason they stay stable on a shelf. But when we give them within, through intravenous infusion, when they reach to the plasma, they get metabolized. Some amount of those products get metabolized, and that lead to a change in vivo strong ion difference. So any product which has in vivo strong ion difference very close to the plasma strong ion difference will be a balanced solution. Okay, so this is something which need to be remembered, how we differentiate between balanced and non-balanced, because strong ion difference of human plasma is between 24 to 29. So any IV fluid which has in vivo strong ion difference close to the plasma strong ion difference is known as a balanced fluid. Any fluid which is not matching with this strong ion difference will be obviously an unbalanced fluid. So that tells you what are the fluids which we commonly use. These are the ringer lactate or so-called Hartmann, plasma light, stereofundin, or gelatin. So if you look at the strong ion difference in vivo, and ringer lactate is the one which is very close. So this is definitely a balanced solution. Plasma light is still known as balanced, and I will answer that a bit later. Stereofundin and gelofusine are not, just again, stereofundin and plasma light are still known as balanced solution, while gelofusine is not, because they have a component which is gluconate or acetate, which get metabolized as soon as they enter into the plasma. As they get metabolized in the liver, their strong ion difference become very close to the plasma, and that's why despite their in vitro strong ion difference which is high, because of this metabolism, they are balanced solution. They are known as balanced solution in vivo, because these products get metabolized as they enter into the plasma. So the examples of so-called balanced solutions are a plasma light, stereofundin, Hartmann, or a ringer lactate, while rest of the so-called commonly used IV fluids like a saline or a saline-based IV fluids like dextrosaline, 3% saline, or GNK, which is which we use sometime for maintenance or sometime even for hyperkalemia management, are all known as unbalanced because their strong ion difference stays 0 as they enter into the plasma. So any fluid whose strong ion difference stays close to the plasma between 24 to 28 or up to 30, they are known as balanced solution. Anything which doesn't stay close to the plasma balanced solution or close to the strong ion difference of the plasma will not be known as balanced fluid. Why this is important? We would be seeing that in few slides, because there have been few studies which have actually evaluated how we resuscitate these patients, comparing the balanced solutions and so-called 0.9% saline. And this was actually based on the last surviving sepsis guideline, where they mentioned that initial resuscitation fluid could be either of the saline or a balanced solution, but later on the evidence actually has been changed, and there is a revision of this particular guideline very recently last year. This was one of the first trial which they used to compare a plasma light versus a saline. There was no difference in hospital mortality, no difference in renal replacement therapy or acute kidney injury. But what was specific probably for the people who are working in emergency unit, like many of you, there is a SALT ED trial where they actually recruited were the patients who were in the emergency department. There they found again the differences were very much minimal in terms of the mortality, but their requirement which was different was in the terms of secondary outcome. So the primary difference, which was hospital mortality, was not difference, but when we added that mortality along with the renal replacement therapy and the patients with AKI or patient who continue to have AKI, there the patient who were actually given a balanced solution found to have a lower mortality as compared to patient who were not given balanced solution. And this was probably the reason SALT ED is very famous trial in terms of looking at the mortality and showing some evidence of balanced solution better than other fluids. But then subsequently there were two large randomized control trial, the basic and the plus, which was actually evaluating again a balanced solution and patients who were given saline. Both of the trial were negative, which means both of the trial did not show any mortality benefit. Now the question would be, when none of the major large trials did not show any mortality benefit, then why we should be considering replacing our so-called cheap saline bag? And that what has been re-reviewed after these, the large two basic and plus trials, which I would be talking in the next few slides. And there the difference is, if you are using probably a very small amount of fluid, if you look at closely at these all four large randomized control studies, most of the studies were very, very large. And since they were very, very large, they recruited almost every patient who are admitted into intensive care unit or in emergency medicine, and many of these patients were actually receiving very small amount of fluid. So probably if you are using a liter of a fluid in 24 hours or maybe 3.5 to 4 liter in 3 to 4 days, that doesn't matter whether you use a saline or your balanced solution. But if you use large amount of fluid, that's the time where you should be very, very careful. And many of the patients who we resuscitate into emergency unit or patients who are really hypovolemic and in shock, they require large amount of fluid. And these two so-called post-hoc analysis of these two large trials, the basic and the plus, actually showed us that, especially the basic one, there were two post-hoc analysis which were done, and where they found, depending upon what you give in these patients, so these patients were actually enrolled while they were admitted into the intensive care unit. But we know the resuscitation do not start from ICU, they start from emergency, where you people are mostly involved. And most of the time we use, as I saw in the answers, many of you are still using saline. And just because we continue to resuscitate these patients with saline, so they found when you included the patients depending upon what they were given in the emergency and also in the ICU, if you are given in emergency and in the ICU both as saline, the mortality was higher as compared to the patient who were given a balanced solution. So it's very important that if you include everything what you are giving, that means you are giving a large amount of fluid. Probably by the time they reach into the ICU, your resuscitation or your mean arterial pressure has already achieved. So probably you become much more careful, and that's why the outcome were not showing any difference. But when we included the patients, or when we included the fluid choice, what was given while the patients were in ER, the way which is more pragmatic, because most of the time the resuscitation actually starts from ER, the mortality difference was refound in these patients, and the balanced solution scored higher as compared to patients who were given saline. What was also important was not just the fluid which was given in the ER, but also the amount of the fluid. So the patient who required large amount of fluid bolus, the mortality was again beneficial, showing towards a lower mortality in patients who were given balanced solution. So there were two important messages which were later on identified by looking at the post-hoc analysis in these trials, that if you are using, or if your patient is really hypovolemic, really sick, requiring large amount of fluid bolus, then you should be very, very careful if you are using a saline. Then your fluid of choice should be a balanced solution, which could be a Hartmann or a Plasma-Lyte or a stereofundin. But if the patient maybe require just a liter of that, it doesn't matter. What is also important is your resuscitation starts from the emergency, because if you are counting the fluid which is only given in emergency or not counting the fluid which is given in ICU or the vice versa, then probably you are missing the link. You are missing that mortality benefit or a survival benefit or a mortality loss. So that's why you should include a patient the way they are presented. Most of the time you start the fluid bolus as soon as you identified with the hypotension. So that two important messages are there, that the fluid which you are giving in emergency is equally important, and you need to be very careful if your patient is really sick. There, more importantly, they will require a balanced solution rather than a saline. And this was also identified in these two large meta-analysis, where they found the mortality benefit was there in patients with sepsis, patient with burns, patient with diabetic ketoacidosis. If you are giving a balanced solution, you are actually giving them a benefit, you are giving them a survival benefit. except in patient with polytrauma, especially patient with traumatic brain injury, where you should still consider a saline, and that is a fluid of choice for these patients. Other than patient with traumatic brain injury, most of the other patients who presented with some sort of shock and requiring a fluid resuscitation, your initial choice of fluid, now evidence says, should be a balanced solution, whether the patient is presenting with sepsis, burns, or patient even with diabetic ketoacidosis. And that what has led to the change in the guidelines, which was there in 2021. Now the recent guidelines talk about balanced crystalloid over saline for volume expansion in most of the patients who are critically ill, whether the patient who have sepsis or even the patient who have even presenting with acute kidney injury. So your resuscitation fluid, except with traumatic brain injury, would be now a balanced solution. What about these starches? In fact, the evidence is very much bleak. I could not find much evidence for gelatin. And this is also, we need to be careful that there is some evidence that, depending upon the amount of volume which you are giving for gelatin in these patients, there is a risk of coagulopathy and there is a risk of worsening, and especially with polytrauma or some sort of surgical patients, this coagulopathy can be very dangerous. So giving them excessive use of gelatin in these patients, first of all, we do not know whether there is a benefit, but there is evidence that some sort of harm can happen if you continue to resuscitate with gelatin. What about albumin? Because the recent guidelines, the 2021 guidelines, still left some sort of room for albumin, and that is probably because we believe albumin is a very important constituent, especially into the endothelial glycocalyx, a new term which has been recently introduced, that the role of albumin is not only looking at hydrostatic pressure or more importantly the osmotic pressure, but their role is much more at the endothelial glycocalyx, the layer which allows the movement of the fluid from the plasma to the interstitium. So the movement which the fluid happens by going from interstitial space to the plasma or the vice versa is decided by albumin, which is lying in the endothelial glycocalyx. So when albumin becomes low or endothelial glycocalyx get damaged, there is a fluid leakage, and there is some sort of physiological rationale that giving albumin may plug up this hole, and that was the reason probably, especially people who have practicing in high income countries, they tend to use albumin, and there were some sort of evidence which was showing plus minus benefit, and this was one of the studies, the SAFE study, where they actually first looked at safety of the albumin, because until then there were few trials which were showing higher mortality benefit. So the primary reason that doing this large so-called study was SAFE study was to show whether the albumin resuscitation is safe. So by showing 4% albumin, but to tell you this comparison was with saline, which we know now is itself a problematic fluid. So as compared to saline, in this particular study, they showed the albumin is safe as a resuscitation fluid. And in a subgroup analysis, they found in patient with sepsis, probably there is some sort of mortality benefit compared to saline if you give albumin. And subsequently, they did this meta-analysis, and that led to, in the surviving sepsis campaign guidelines of 2021, talking about that we suggest using albumin in patient with who have been given large volume of crystalloids. So if patient who has continued to stay fluid responsive and patient who remain hypotensive, and you have to give some sort of fluid, probably after use of large volume, we don't know what is large volume here, but at least 21 guidelines said that you can consider albumin. However, re-reviewing the whole evidence, the evidence did not show the major mortality benefit or major benefit in terms of use of albumin, plus the issue of availability and the cost led to revision of the guideline. So very recent guideline which came last year. Now the evidence says crystalloid is most importantly a fluid of resuscitation in most of the patients in intensive care unit. So role of albumin is very, very bleak or very, very fuzzy. If you have to use, you have to give a very good reason, because evidence does not support. And then of course you are using a blood product. More importantly, you are using an expensive product, and the cost is an important component which we do consider every time when we manage our patients, and is important for everyone who is managing or working in a resource limited setting. So evidence does not speak on use of albumin anymore in patients who require resuscitation, most of the patients who we see in the intensive care unit or in the emergency. So if I ask you, the evidence currently just left is with a balanced solution, and to tell you, there is now a good evidence that even ringer lactate is very much applicable to be considered in that balanced solution and can be your fluid of resuscitation in most of the patient. Though plasmalite and sterophundin has been tested much more often into the large trials, this could be also because most of the trials actually got support by these so-called balanced solutions. But evidence is some favoring for even Ringer lactate as compared to the saline. So definitely saline should not be longer a fluid of resuscitation. It should be left for some other things, but definitely not for resuscitation. Gelatin and albumin, again, just because the evidence is not great, plus they have their own problems. So you need to be giving a very good reason to consider using these fluids. And the only good fluid evidence-based or evidence-based fluid which need to be used in so-called resuscitation is a balanced solution. So we talked about fluid responsiveness. We talked about different types of fluid. We also talked about early vasopressor. But I put a lot of emphasis so far was fluid tolerance, and that actually led to believe whether we can restrict amount of fluid. So in the last decade or so at least, there was some amount of discussion whether this so-called 30 ml per kg of fluid or looking only for giving fluid and fluid boluses, can we use a strategy where we can restrict the amount of fluid depending upon use of early vasopressor, the way I showed you earlier. So there is some debate on that, and this large randomized controlled trial which was published in NEGM in a couple of years back, where they tried to use a restrictive strategy to manage these patients as compared to the standard strategy which we are following based on surviving sepsis campaign by giving 30 ml per kg or using fluid responsiveness to continue resuscitating these patients by looking at the mean arterial pressure. So this was so-called what we do, and this particular RCT compared a restrictive strategy as compared to what we usually do, and they did not find any mortality difference by using either a restrictive or a standard. So at least one message is there. Maybe certain patients can be benefited by restriction, but yes, it doesn't mean that every patient need to be restricted. There are patients who will require continue to be resuscitated with fluid, while other patients still need a restriction. But the trial was negative. At least it did not show any mortality benefit with restriction. And this was slides which we took from Professor Tina, who was the first author of the study, who presented this in one of the Fluid Academy days where I'm a regular attendee now. And this was in the 22 where she presented her own data. The study did not show any mortality benefit. There was no difference in the subgroups also by restrictive fluid strategy as compared to somebody who has been given a standard fluid strategy. So at least by looking at purely at this study, you can say yes, what we are doing is not bad. At least it's not been shown a difference in the terms of outcome. But if you look closely again, as we look at the previous large fluid trials, what was there was amount of fluid. So if you are giving very limited amount of fluid, then probably no. But if you are giving a large volume of fluid, then probably you need to consider a restrictive strategy rather than a standard strategy. So-called, again, the message which was being repeated is the patient who are really sick, the patient who are really hypovolemic, or the patient who require large volume of resuscitation, probably fluid choices will be something which can show definitely an outcome difference. So that message is getting repeated again here. That's the message which was coming previously, that balanced solution would be an ideal preferred fluid in these patients. Again, the message is, again, if you are patient who are really sick, it means the patient who require large volume for resuscitation, probably giving them or continue using a fluid boluses for them will not be beneficial. You need to be careful. You can consider starting an early vasopressor or try to do a source control for these patients. Probably their continuing only giving fluid will be harmful, and that what was found in the post hoc analysis. So if you are given a standard and a restrictive fluid strategy, the larger the fluid bolus, so if you are giving not much fluid to these patients, it doesn't matter whether whichever strategy you follow. But if the patient is requiring a large amount of fluid bolus, then definitely a standard strategy will be having a higher mortality as compared to the restriction. So these are the patients you need to be careful that you should stop continuously looking at fluid responsiveness. Now these are the patients who also need to be looked at fluid tolerance, and probably they are the patients who will be likely to get harm if you continue to resuscitate these patients with fluid. And that what probably will be reflected in the last few slides here. So the same patient which we discussed in the initial few slides already have been possibly now diagnosed as perforative peritonitis after a surgery. So she was operated for. after surgical drain and an open abdomen. She was already given 4.5 liter of ringer lactate, or probably in some scenarios a plasmalite, as the initial part of resuscitation. Now her MAP is 60. She is already on a norepinephrine of 0.35 mics per kg per minute. Her blood gas still shows some amount of metabolic acidosis with lactate of 3.2. Already she is on some sort of hemodynamic monitoring and currently with a stroke volume variation of 11, SVRI of 821. So she is still vasodilated with a urine output which is picked up, which was nothing, until first 24 hours, has improved in last few hours. So she is producing now 30 ml per hour, and these are her, so-called UNEs or other labs which are already there. And then blood sugar is 5.6, not hypoglycemia. This is different from, UK SI units, the way you use it in India. So she's not hypoglycemic here, but definitely has still low oliguric. There is a metabolic acidosis. Lactate is 3.2, MAP is 60, and she already has received 4.5 liter of ringer lactate. So what will you do next after hearing me for last 15-20 minutes? Whether you will consider increasing the norepinephrine, giving an IV fluid bolus, will consider adding a second vasopressor, which is a vasopressin as per the guidelines, or you will change the antibiotics. This is to tell you is second day. Will you consider adding a corticosteroids or adding an albumin for these patients? So what do you think would be a right choice for you? You can post your responses again in the chat box. Okay, add vasopressin. The norepinephrine is there, so I assume you wanted to increase the norepinephrine. Okay, any other things which you want to consider? You can, have given you few choices. Of course, if you think of any other choice or any other fluid or any other vasopressor, please feel free to put up into that, and again, something which we are always encountering whenever patient reach up to the ICU in the first 24 to 48 hours, they continue to stay unstable. So what will be your choice? What about fluid resuscitation and CKD with DK? I will try to answer these things later on, but related to the question which I put now, if you can put up your options. Okay, adding a corticosteroid, fluid bolus, add a vasopressin. Okay, 10 seconds more if you want to type your choices or type your responses, please feel free. Okay, so I see a mix of responses now. Steroid, vasopressin, increasing norepinephrine. Add, that's all. Yeah, increase. So mainly people are saying increasing norepinephrine, vasopressin, and the third was basically adding a corticosteroid. Okay, many of you are saying that fluid bolus no more. Can I know why no one is agreeing with the fluid bolus? It's just because I talked so much about or against the fluid. It's the only reason, or there is some message which was coming in the last slide. That's the reason you are saying you don't want to give any more fluid. So patient is still hypovolemic. Patient is still not hypovolemic. Patient is hypotensive. That's not a right word I said. So patient is hypotensive. Patient has signs of organ hypoperfusion. So patient is in shock, hypotensive, shock, and possibly there is no other reason now to say that there is the patient is not in septic shock. So she is still in septic shock with with MAP of 60, with lactate of 3.2. MAP was maintained. Okay. I would not agree with that, because we, as per surviving sepsis, we need to tend to maintain MAP of above 65, especially when there are other signs of organ hypoperfusion. So her lactate was high. Urine output is still not good enough to say that you patient is not in shock. So patient is in shock. More fluid will lead to fluid accumulation. Yeah, that's very important, and I think very important answer. But what is a message which is stopping you? So I asked you, I told you rather three things you should always consider. One is patient is need to be hypotensive. So if patient is hypotensive, then only you should be considering a fluid, which means the patient has a low cardiac output. So hypotensive and or organ hyperperfusion. In this case, That answer is yes, patient is hypotensive, and definitely there are evidences of organ hypoperfusion. The second question was you should ask is whether patient is fluid responsive or not. Is this patient fluid responsive? Yes or no? Responsive. Okay. Why you said why responsive? The stroke volume variation is 11, to give you a hint. So it's one of the dynamic tool which we use to assess the fluid responsiveness, and value above 15% is known as responsiveness, while here the value is 11%. So I would not agree with you with that. Okay, so this is not a responsive fluid. Okay, so somebody has posted as per dynamic indices of fluid responsiveness and fluid primarily treated with, I have not understood. Yeah, fluid. So at least stroke volume variation is not agreeing with responsiveness state. Okay, and the final third thing was a fluid tolerance. So we have not talked about fluid tolerance, but since our second question itself was no, definitely you should be avoiding any more fluid boluses in these patients, and that's the reason that is out. Now we are left with either increasing norepinephrine, adding vasopressin, change antibiotic. I don't think it's too early to even consider. You have done an adequate source control. It's just a part of the sepsis and shock which is causing this problem. It's too early to even consider a change of antibiotic unless you have identified something on the surgery itself, which I have not mentioned. So that's definitely you should be not considering now. Adding albumin, as the evidence does not point out very much for adding albumin because it has its own problem. So yes, albumin is out. So now we are left with norepinephrine, vasopressin, and steroids. I saw all three of you have given, some of you have given vasopressin, norepinephrine, other have given steroids. So we'll be seeing a bit later. But when to stop IV fluid? The important thing is when cardiac output is adequate, which was not in this case, and the preload responsiveness is unlikely. So you should stop fluid when one of the answer is no. So you should ask three questions to yourself whenever you think of IV fluid. And the first thing was cardiac output, which was low in this case. The second question was preload responsiveness, which was with stroke volume variation. I have not given you any other evidence. So with stroke volume variation, there is at least you can say the patient is no longer fluid responsiveness, but you need to check other things before looking at stroke volume variation. So I'm not going into detail of that, but the second question was no for this patient. Definitely, that's the reason you should consider stopping, or you should not consider fluid bolus. So answer probably lies in, in the second vasopressor and corticosteroid, because now the surviving sepsis guidelines say that anytime you have a dose of above 0.25 mics per kg per minute of norepinephrine, you should consider a second vasopressor, which is vasopressin, as the drug of choice, and that's the reason that's the right answer. And possibly if the patient stays hypotensive even with adding of the second vasopressor, these are the patient where you can consider adding a steroid. So these are the possible options which are there for this particular patient. It depends whether you want to consider steroid, but important thing is if patient stays with hypoperfusion and you have already reached norepinephrine above 0.25, then you should consider a second vasopressor. At least the evidence talks about that. So giving fluids to only patient who need it is the most important factor you should consider. It's not the answer every time you see a patient in shock or patient in hypotension. And the other important thing which I wanted to put focus was using a smaller fluid boluses. 30 ml per kg does not give you answer for everyone. It does not, it is the amount of fluid which many patients may actually receive, but it doesn't mean that you have to consider everyone with a 30 ml per kg. You can consider a smaller fluid bolus. Most importantly, look for the dynamic goals of resuscitation. So it's no longer valid that you continue to give fluid bolus. Do not look the assessment of these patients. So every time you give fluid, the way you do it with any other drug, you look at the response. So you look at the response in terms of whatever the targets you have kept, whether increasing the mean arterial pressure or an cardiac output, that need to be reached before giving the next fluid bolus. And the third thing is you should also look at something known as fluid tolerance by various other tools, which I have not talked today, but that should be the third thing which should come in your mind before giving a fluid bolus, that patient is fluid responsive, patient is hypovolemic or in shock. But why I'm still not giving fluid, probably because patient is having a leaky capillary. So further giving fluid in this patient may lead to harm. So the fluid is very much a balanced game, and we need to consider many things. There is always, we should consider fluid like a drugs, a right amount, the right concentration, right amount, right type of fluid, and at the right time where actually things can improve outcome of these patients. Otherwise, you will continue to see a patient who is swollen up, going into fluid accumulation syndrome by second or third day, and will be dying not just because of the primary disease, but also because what we have done in the initial few days. So this is again the link which, if you have not downloaded, again a free book, a very useful book, very has become very popular book. I don't know whether just because it is free to download or if people are really liking it. So if you want to give me a
Actually,
feedback, probably,
it used
yeah.
I used that book personally, sir, and it helped me very much.
Thank you.
So
Okay,
support.
that's really helpful. It's really nice to hear that. But yes, looking at the way the book has been downloaded, we were really assured that people are really wanted to learn.
Book
And I
is
think
available
probably,
online, sir.
yeah, it's available online, and that's
Really.
no need to, probably one of the book which you need not to share or to ask anyone from the WhatsApp group. You can freely download by using this QR code. And of course, I want to acknowledge Professor Melbrain, who is actually a mentor, but at the same time talk about fluid a lot. This is all my social media contacts. If you want to learn more about fluid or want to give me any feedback, you can also give it over here. Or you want any of the slides or probably some of the original paper which I shared, you can either reach out to me, either of the three things, or leave this email on this feedback QR code, and I'm happy to learn much more about what you want to do, or probably doing it to your bedside, or probably if you want to learn more about fluid stewardship, again this is an opportunity to reach out to us. Thank you. Thanks for listening.
So
I'm
yeah.
sharing my slides. Yeah.
Thank you very much, sir. Even offering for to share the slides, that is also really nice of you. I would like Dr. Shubhankar Paul, sir. He's our academic head of our Society of Acute Care Trauma. He's a critical care physician, MD emergency and DRM critical care. So he'd like to say a few words.
Yeah, good evening, sir. I have listened to you so many times in the past as well, and there is so
Okay.
much to learn every time when I hear from sir. So on behalf on behalf of the residents, someone has put a bit question. I just will ask one or two questions. One, someone has asked, what about fluid resuscitation in CKD with DKA?
Okay. There is no difference whether you use a CKD patient or a patient with AKI, because again, something which I sometimes talk about, the myths related to the IV fluid. So the balanced solution, it could be a plasmarite or a ringer lactate. They are the drug of choice. We actually published a meta-analysis last year in Indian Journal of Critical Care Medicine, and now there are 4 meta-analyses talking about fluid of choice for DK, and probably the next guidelines will revise that. So balanced solution, ringer lactate have definitely shown amount of benefit. They may not have shown the mortality benefit, but they definitely have shown the way we treat them. The most commonly these patients actually tend to receive normal saline, or so-called 0.9% saline as the initial fluid. But the evidence says by giving a balanced solution, you tend to correct their electrolytes. More importantly, their anion gap, and the risk of giving saline, which is hyperkalemia, is not there with balanced solution. So their reversal of anion gap is much faster when you give a balanced solution. Second thing is you tend to produce less hyperkalemia and less risk of AKI in these patients. So patient with CKD and DK, I would tend to resuscitate these patients based on a balanced solution, which could be either a plasmalite or a ringer lactate.
Thank you very much, sir. And one query is keeping in mind that it's a tropical season. So any role of colloids in dengue hemorrhagic fever and dengue shock syndrome patients?
Again, something people have talked about a lot. Unfortunately, there is no evidence. So we tend to, even when I was back in India, we were managing a lot of dengue patients. We try to look it into it. There are some people who talk about albumin because these patients actually require large amount of fluid. Unfortunately, we do not know enough whether the leaky capillaries, which are known with dengue shock syndrome, is getting any benefit in terms of using albumin, or even that matter for a fresh virgin plasma. So yes, at present there is no good quality evidence to support any of these two, and then they have their own problems. So right now I would still recommend a balanced crystalloid as the initial fluid of choice.
Thank you very much, sir. So, sir, has summarized even the trials, though most of the ICUs, though most of those trials are mainly for critical ill patients in ICU, but sir has summarized them so well to be effective very much for the emergency residents as well. So, thank you very much for sir for taking your time out for emergency medicine fraternities. And with this, I think we
I
can
think
stop for this.
there is one more question probably to plasma light if you have time, which
Okay,
I'm
sir.
seeing. Yeah, it's a strong
Yeah,
ion difference. So
SI has
strong,
it of.
yeah, I think probably this is all because the what is the constituent. When we talk about strong ion difference in vivo and in vitro, it gets different because the metabolism is there happening, which is in vivo of acetate and all that. So that changes so-called strong ion difference of plasma light. And that's despite being strong ion difference of 50, it is known as balanced solution because the product which is causing this 50 strong ion difference get metabolized very rapidly into the liver, and that will bring the plasma light strong ion difference close to the plasma, and that's why it is still labeled as a balanced solution.
Yes, very nice, sir. Thank you very much, sir. So thank you all the participants who have participated today and make this interactive webinar. I think it's a grand success. And thank you, Nayan.
Yeah, thank
Thank
you,
you, everyone.
everyone, because even being a festival today, you have all joined. I really appreciate your
Yes,
dedication for medicine. So, sir has come from, I mean, joined from UK, and I'm really grateful for the accepting, sir. So, thank you, everybody. And
Thank you, everyone.
if any questions, you can reach out to sir on the social media handles.
yes, fine.
Thank you. Thanks everyone. Bye. Have a
Thank
nice
you,
day.
Thanks.
Thank you,
Thank you,
sir.
sir.
Thank you, everyone.